Hi, my name is Poonam Velagapudi, and I'm an interventional and structural cardiologist at the University of Nebraska Medical Center. And today I'm going to be talking about transcatheter mitral valve repair for secondary MR and the data behind it. So as we all know, the prevalence of mitral valve disease is 2 to 3 times that of the aortic valve disease, and MR is more common of the two mitral valve disease disorders. These two types of MR, we're going to concentrate on the secondary MR, which you'll see on your right, secondary to LV dilation, causing leaflet tethering, mitral annular dilation, and thus causing incomplete coarctation of the mitral valve leaflets. Now, severe MR is a progressive disorder and it causes LV dysfunction, heart failure, and annual rate of death is 5% or more without intervention. Now, medical treatment can alleviate symptoms, but it does not alter progression. So historically, surgery was the treatment of choice, and one such surgical repair, the creation of the double orifice, has had successful results lasting up to 12 years. And MitraClip is a percutaneous form of creating that double orifice repair, and this is what I'm going to concentrate on in today's presentation. So the prevalence of secondary MR is 2 to 3 times higher than that of the primary MR, and we know that 1 in 5 of heart failure patients have moderate to severe and severe secondary MR. Now, secondary MR itself is a predictor of mortality, and what it does, it increases the load of stress on the LV, causes muscle damage and loss, dysfunction of the left ventricle, and then dilation of the LV, and it is a cycle. And the 1-year mortality can be up to 57%. It also worsens heart failure outcomes. As you can see here, hospital-free survival and the transplant-free survival are both decreased with increased MR severity. And the 2017 HACC valve guidelines recommend mitral valve repair or replacement for severely symptomatic NYHA class 3-4 chronic severe secondary MR who have persistent symptoms despite guideline-directed medical therapy as a class 2B recommendation. And we all know that guideline-directed medical therapy for HFrEF patients is a class 1 indication, and so is the CRT therapy according to the 2014 ACC/HA guidelines. Now, the MitraClip was approved for primary MR treatment in 2013, and for the secondary MR, it received approval on March 13, 2019, and specifically for patients who are on maximally tolerated guideline-directed medical therapy and have moderate to severe MR. Their grade is greater than or equal to 3 per American Society of Echo criteria, and their EF is between 20 and 50%, and LV end systolic dimension less than or equal to 70 millimeters. And where does this come from is the the most important trial, which is the COAPT trial, which we'll discuss here. So the COAPT is a multi-center randomized trial of 610 patients with heart failure and moderate to severe or severe MR who remain symptomatic despite maximally tolerated guideline-directed medical therapy. They were randomized 1:1 to MitraClip plus medical therapy versus medical therapy alone. These patients had an LV ejection fraction between 20 and 50%, and their LV end systolic dimensions were less than or equal to 70 millimeters. So important to keep that in mind. Now, these are the baseline characteristics. The primary effectiveness endpoint of this trial was all hospitalization for heart failure within 24 months. And you can see the MitraClip group had lower primary endpoint with a number needed to treat of 3.1. And similarly, the trial also met the primary safety endpoint, which was freedom from device-related complications within 36 months. In terms of survival, MitraClip plus guideline-directed medical therapy was better than guideline-directed medical therapy alone, with a number needed to treat of 5.9. And these are powered secondary endpoints. But this is one of the most important slides here, is that there was improvement in quality of life with MitraClip and guideline-directed medical therapy. As you can see here, these patients were 2.5 times more likely to experience a large improvement in quality of life with the MitraClip. This is the mitral regurgitation at 24 months. We can see that the MitraClip group had greater than 95% of the MitraClip group patients had an MR of less than or equal to 2+ at 24 months. So something So the results are pretty good at 24 months. Now, this is 24-month death or heart failure hospitalization by subgroup, and you can see that the results are pretty consistent across all the subgroups. And then you also have results for 36 months. Primary effectiveness endpoint of all hospitalizations was still lower for the MitraClip group with a number needed to treat of 3.0. And this is the survival, which was also lower with the MitraClip and guideline-directed medical therapy at 3 years with a number needed to treat of 7.9. And all-cause mortality or heart failure hospitalization combined endpoint was lower with the MitraClip group, as you can see here, with a number needed to treat of 4.5. Now, the other important trial that came around was the MITRA-FR trial. This was a randomized trial of 304 patients with secondary MR due to LV dysfunction. Their ejection fraction was between 15 and 40%, NYHA class 2 to 4, hospitalization for heart failure within the previous 12 months, and those were not eligible for mitral surgery. Their MR was defined by EU severity criteria of EROA of greater than 20 millimeters square or regurgitant volume greater than 30 mils per beat, and were randomized to MitraClip plus medical therapy versus medical therapy alone. And the primary endpoint was freedom from death or heart failure hospitalizations through 12 months. And as you can see here, the primary composite endpoint was not different between the two groups. So why is this? Why was there no difference in this group where COAP trial showed a benefit? So here are some of the differences. The pre-specified entry criteria, for example, the COAP trial had patients with severe MR being defined by US guidelines, EROA of greater than 30 or regurgitant volume more than 45, whereas MITRA-FR was less severe MR with EROA greater than 20 or RV regurgitant volume greater than 30 mils per beat. The LV and systolic dimensions had no limits on the MITRA-FR, so even very dilated ventricles were included, whereas in the COAP trial, you had LVs that were less than equal to 70 millimeters in the prior 90 days. Now, in terms of the proportion of patients who had and the severity of the MR, you can see that in the MITRA-FR group, about 52% patients had an EROA less than 0.3, whereas the COAP group, there was only 14%. In the MITRA-FR group, the 0.3 and over were about 48%, whereas over 87% of the COAP patients had their EROAs of greater than 0.3. The other big difference was the guideline-directed medical therapy. In MITRA-FR group, there were medical adjustments done during the trial, whereas for the COAP trial, these patients were all on maximally tolerated guideline-directed medical therapy, and no significant changes were made during the trial. So an important point to keep in mind. So with that, I'd like to, this is a good slide to show which group of patients would benefit from the MitraClip therapy. So on the bottom is those patients who have a mild to moderate MR, in which group that MitraClip would be futile. Whereas in the upper half, you have patients with moderate to severe MR with regurgitant areas of greater than 30 millimeters squared and regurgitant volumes greater than 45 mL. And you can see that on the left, the group has an LV systolic dimension of greater than 70. So on the right, the LV systolic dimension is less than 70. So the group on the right would be the one that would most benefit from the MR, or so-called the disproportionate MR, where the LVs are not too big, but the mitral regurgitation is severe, indicating that there is some sort of a mitral valve pathology which can be fixed with the MitraClip. On the left side is the group that is severely dilated ventricles and with an MR, which is a proportionate MR, where probably guideline-directed medical therapy and other ways to treat the LV dilation may be more beneficial. So with that, I will end and thank you for giving me the opportunity to speak today.